Hello, my name is Nicole Smith. I will be dictating a history and physical for a 53-year-old female seen with the hospitalist service. Her chief complaint is general malaise and abdominal pain. The patient was actually discharged home from a 5-day hospitalization due to CHF exacerbation yesterday. She presented to the ER this early morning with complaints of general body aches and abdominal pain. Per the ER report, the patient was alert and oriented ×3 when seen initially and has gradually declined to arousal with pain over the course of about 2 hours. The patient is slow to answer questions but does with time appropriately. Upon physical assessment in the ER, the patient exhibited a rigid abdomen as well as very tender to light stroke across the skin of the abdomen. A CT with IV contrast of the abdomen and pelvis was ordered and completed with results concerning for a gastric perforation with free air in the abdomen. The patient received 2 milligrams of morphine in the ER and a dose of Cipro 400 milligrams IV. She was admitted to ICU, to the services of general surgery, and the hospitalists have been consulted as medical consultants. The patient's vitals on admission to ICU are a temperature of 100.2. Blood pressure is 84/53. Her pulse is 117 sinus tach. Respirations are 24 breaths per minute. Her sat is 98% on 2 liters nasal cannula. The CT scan results were mentioned above. Her chest x-ray was within normal limits. Her EKG was within normal limits. Renal function is intact. White blood cells are elevated at 12.4. Her procalcitonin is very elevated at 4.2. And her potassium is low at 3.1. The patient's currently NPO has been placed on the OR schedule for emergency surgery today. She has a past medical history of CHF and COPD. She has a left pacemaker defibrillator and no other surgical history. The patient does take lisinopril 20 milligrams daily, Lasix 40 milligrams PO daily, potassium 10 milliequivalents daily, Norco 10 milligrams 4 times daily for chronic back pain. She takes a Spiriva inhaler daily for her COPD, and she has an albuterol inhaler that she can take every 2 hours as needed for shortness of breath. The patient does not have any current known allergies. She does live at home with a significant other. She is a current pack per day cigarette smoker and 6-pack of beer daily drinker for about 40 years for both. She does not work and overall appears to have a history of noncompliance with her health care. Her parents are deceased, but I cannot get any other family history from her at this time, and she does not know if her immunizations are up to date. For review of systems, this is difficult to obtain due to the patient's untended state. She did answer questions. It just did take her a very long time. She does deny blurred vision or visual changes. She denies any ringing in her ears or hearing loss. She denies ear pain. She has no sinus issues that she reports. She denies any soreness or difficulty swallowing in her throat. She denies any confusion or dizziness. She does report a history of COPD and is a current everyday smoker. She uses her albuterol inhaler when she has episodes of shortness of breath, but denies any current shortness of breath. She denies any chest pain or heaviness and reports a history of CHF. She does report sudden abdominal pain with onset early this morning. Reports the pain as diffuse throughout her abdomen. She does report her last bowel movement was yesterday and states that it was normal. She denies any pain or bleeding with urination. She denies any arthritis, but she does report a history of chronic back pain. She denies any skin issues, no eczema, dermatitis, or acne. Upon physical exam, her vital signs were reviewed and are as follows. 100.2 temperature, blood pressure is 84/53, pulse is 117 sinus tach, respirations are 24, her O2 saturation is 98% on 2 liters nasal cannula. General appearance, excuse me. The patient appears to be underweight. She is a Caucasian female. She's lying supine in the hospital bed. She is obtunded and does answer questions very slowly, but appropriately after sternal rub from the nurses. The patient is pale and appears to be very ill. Her head appears normal with no noted malformations or trauma. Her facial expressions are symmetrical bilaterally. The patient is Perla, 2 millimeters bilaterally. Her eyes are free of redness or drainage. No exophthalmosis noted. No pain or discharges noted with palpation. Excuse me. The patient has no apparent signs or symptoms of hearing difficulties. Her ears appear normal and symmetrical bilaterally. Her tympanic membranes are pearly gray with landmarks and cones of light visualized bilaterally. She has no nasal redness or drainage. Her neck is supple without swelling. Nodes are within normal limits during palpation, and her throat is clear of redness or drainage. The patient does not have JVD. The patient is 98% on 2 liters nasal cannula. No dyspnea is noted. Her respirations are even and unlabored. Her rate is tachypneic at 24 breaths per minute. Her lungs are clear bilaterally but diminished. Her blood pressure is 84/53. She has sinus tach 117. S1 and S2 are present without gallops, murmurs, or rubs. Her cap refill is less than 2 seconds bilaterally. Her left chest pacemaker defibrillator is noted. I did find an old echocardiogram on file that reports an ejection fraction of 25% in March of 2014, which supports her history of congestive heart failure. Her abdomen is flat and rigid. Her bowel sounds are present in all 4 quadrants. There are no masses felt with palpation, but guarding and rebound tenderness is noted. The patient pretty much comes off the bed with any sort of light palpation to her abdomen. She does deny any nausea or vomiting. She has no kyphosis or scoliosis noted. All her cranial nerves are intact. Sensation to light touch is intact bilaterally. Her deep tendon reflexes are intact bilaterally. She does have weak grips bilaterally, and she's currently obtunded but converses minimally to painful stimuli. A review of her lab and radiology findings I have stated above. Her CT of her abdomen and pelvis with IV contrast show a highly suspicious perforated gastric ulcer. Chest X-ray and EKG were normal. Her renal function was normal. Her potassium was low at 3.1 and her procalcitonin elevated at 4.2. Her white blood cells are also 12.4. Diagnosis are as follows. Number 1, perforated gastric ulcer. Number 2, sepsis. Number 3, hypotension. Number 4, hypokalemia. And number 5, altered mental status. The plan is as follows. The patient is going to be admitted to the surgical services with hospitals consulting for medical management. She's going to be kept in the ICU. She's going to be strict MPO. I want her to have 1 liter normal saline bolus, and after that is complete, I would like the nurses to start her on Levophed at 0.2 mics per kg per minute to keep her systolic blood pressure over 100. Saline is going to be her primary fluids at 150 cc's per hour. Would like blood cultures and urine cultures collected. K-riders for potassium replenishment, 20 milliequivalents, IV piggyback every 2 hours for a total of 2 doses. Started on a protonic strip at 10 milligrams per hour continuous. Morphine 4 milligrams IV every hour as needed for pain control. We're going to continue the emergency room's dosing of Cipro 400 milligrams every 12 hours. Going to add Marum 1 gram IV piggyback every 8 hours and Flagyl 500 milligrams IV piggyback every 8 hours. Place her on continuous cardiac monitor and continuous pulse ox. Nurses are to do neuro checks every 1 hour and chart. The patient is going to have a central line placed and an art line placed in the OR. Upon arrival back to ICU, I would like a CVP reading and art line pressures. The current plan, as discussed with surgical services, is to leave the patient on the ventilator postoperatively, stabilize her overnight, and evaluate her weaning potential in the morning. And the patient is a full code at this time.